We're going to talk about assessing nutritional status, chapter 13. The objectives for this chapter are understanding the foundations of nutrition, what has impacts on hydration, malnutrition, overnutrition, dehydration, and overhydration. You're going to explain the nutritional assessments, the screenings, describe some of the subjective data we might talk to our patients about, and some of objective findings that would indicate to you about nutritional status of your patient. We're also going to briefly discuss the measurements that we utilize, height and weight, and BMI. And for those findings, you would want to know that information because there are some medications that are weight-based, so we want to give those measurements as well. So when you're assessing for specific for hydration or specific for malnutrition, think of some of those abnormal findings that you would be looking for. And know some of these tests just for yourself. Weber and Kelly does not note these in the chapter, but you should know these. Sodium, potassium, chloride, magnesium, hemoglobin, and hematocrit tell you about the volume of fluid in the body. Cholesterol, triglycerides, albumin, and protein are also lab findings that are important to acknowledge and look at when you are assessing somebody's nutrition. So again, nutritional assessment gives an insight to the health status. Your patient may be coming to the hospital with a disease process, but their baseline health status can really dictate how their recovery is going to go and if there is presenting issues. So looking at some of the nutritional deficits, whether it be malnutrition, undernutrition, or their hydration. A lot of patients come into the hospital dehydrated, poor urine output because of their hydration status. So we're going to be looking at a lot of those things. So the nutrition assessment, just in briefly, understanding the impact of carbohydrates, proteins, and fats, including vitamins and minerals on the body. The body needs all of these kind of things. Some things they can get through foods, some things through water, things like that. But you need to know what your patients need to remain healthy, because we are going to assess their baseline and work with them from there. So for your patient's hydration status, again, it's an indicator of good health. Your body is made up of a lot of water. And so when patients are dehydrated, this puts them at a huge deficit for body organ function and for healing. So adequate hydration can be affected by elevated temperature, sweating a lot, poor access to fluids. There are some things that diuretics and alcohol and caffeine can be dehydrating. As patients get older, that impaired thirst mechanism that we have talked about previously can be a real issue for patients. So also patients who are diabetic and have some issues with hyperglycemia may experience issues with hydration as well. In some of the dietary guidelines, there is the plate that you've probably seen quite a bit of that, where you have a half of your plate is fruits and vegetables, the other half is protein and grains, and dairy is included as well. Looking at the impacts of sodium and those added sugars on the diet is something that we review quite a bit. The USDA has published guidelines for dietary considerations, and we really do refer a lot to nutritionists in the hospital setting to help us navigate some of these things, because there's some allergies. Some patients have specific requests, or maybe are vegetarians, and we really work with them a lot while they're in the hospital to help accomplish their nutritional goals. So optimal nutrition status is when there's sufficient nutrients to do what the body needs. Malnutrition is when those reserves are depleted and can possibly risk impaired growth. Once all the calories have been burned and there's no fat left to burn, the body starts taking the energy away from the muscles. And we actually see patients who have malnutrition with muscle wasting. Overnutrition is an issue as well, consumption of nutrients that's in excess of what the body needs. And so if it's more than what the body needs, the body stores it as fat. And that fat can be stored in the abdomen. It can be stored around organs. So you've probably heard of fatty livers, and that can be an issue for your patients as well. So again, some of the risk factors for malnutrition is fast food, poor food choices, maybe dieting or illnesses, disease processes such as cancer and HIV, AIDS, leads patients to not having much of an appetite. But that can happen as an older adult as well. The appetite decreases. A lot of times with metabolic needs decreasing, their appetite decreases as well. So we have to be very specific about what kind of foods give you the most bang for your buck. Now, signs and symptoms of malnutrition can possibly be confused with other diseases. So we really look at the onset and the patterns of patients when we are recognizing that they have malnutrition. We look at their lab values, their proteins, their prealbumin and albumin levels in the blood. Now, overnutrition, that increased calories and less energy expenditure. We look at a bunch of patients who are overweight versus obese, and some of these numbers are calculated by measures that don't always seem appropriate to everyone. Overweight is 10% over the ideal body weight, but for many patients, the ideal body weight is not what you would expect. I remember when I was a kid, they said 100 pounds for, if you're 5 feet, it's 100 pounds, and then for every inch over that is another 10 pounds was the allowance. So if you were 5'4", that would be 140 pounds. But that's not the same for everybody, and times have definitely changed. So really there's a lot of factors that go into assessing somebody's nutritional status. So we take these things with a grain of salt when you're looking at ideal body weight. What does that mean? So you also probably have heard words like obesity and morbid obesity, which is 20% over ideal body weight. There are some health risks with overnutrition. The body has to work harder to navigate the additional weight, joint-wise, heart-wise, blood pressure-wise, things like that. So those are things to consider when you're looking at somebody's nutritional status. So dehydration, we talked about that, just the overall volume in the body. You need that for your body cells and organs to function well. So with serious illnesses, there can be insufficient fluid intake, either by mouth or parenterally, which is IV. And so if your patient is not able to take fluid by mouth and we recognize they're dehydrated, we will give them IV fluid to help because we know that's such a crucial thing for your patient. Now, the overhydration is not typically a major thing with a normal person, unless there was some type of issue with the kidneys and the lungs as far as balancing the fluids. So fluids move through urine, stool, your respiration and perspiration in the body, and the body balances itself. You have probably heard about all those things in patho, renin, angiotensin, all those type of things as the body is recognizing what it needs to do to remain in a homeostatic position with hydration. But when the fluid gets too much, sometimes patients might feel that peripheral edema in hands and feet, or fluid on the lungs, like pulmonary edema. So with patients who are at risk for those things, we really watch how much IV fluid we're giving them. If we're giving it to them too fast, that can be negative. So looking for those signs of overhydration is important too. So when your patients come into the hospital, they bring their previous habits with them, what they like to eat, when they like to eat different types of foods, and they eat at a certain time, and they like to have this particular thing in the morning. And so we were going to talk to them about that. If they have specific beliefs on days about food and their nutrition, we have to learn about what kind of things would be safe for your patient. And this can be a real challenge if patients need to understand how nutrition and those type of things might impact their recovery. So, for example, if somebody wants to fast, but we are dealing with a healing situation where they need to have the nutrition, they need to have the protein in order to heal a wound, that may be a discussion to have with the physician. So just giving an estimate of how many calories your patient needs, this is a complete estimate. You are not going to have to calculate this thing. It's just for your information to give you a little bit of a ballpark. Now, your nutrition assessments, when your patient comes into the hospital, we're going to talk to him about what their appetite's been like, what has their diet been like, how much hydration, water, are they drinking coffee, alcohol, those type of things during the day, and do a screening. Now, if we identify if they have those big diagnoses that are impacted by the diet, such as cardiac diet, renal diet, and sodium diet. If your patient has any type of hepatitis or cirrhosis, things like that, we also look at the proteins. And so low protein diet for those patients. So we're going to, if there is an issue, we're going to get a referral to the dietitian and make sure you document what type of diet your patient has been experiencing. So in a comprehensive nutritional assessment, you're going to collect all the subjective data, any objective data, their anthropometric measurements, their height and weight, things like that, especially if there's some abnormal findings there, and you will utilize that for your dietitian referral. A mini nutritional assessment is typically for older adults, maybe long-term care or community centers. If there's any changes in their intake, which happens sometimes, patients, if they are depressed or maybe they're in grief, they have had a loss or something like that, lacks of appetite, or any digestive problems, maybe reflux, constipation, that may decrease somebody's interest in eating. Any chewing or swallowing problems like dental issues might be a concern. Weight loss, recent weight loss is always something that we look at, especially if it's more than 10, 15 pounds. Mobility to get to food or stress might impact their nutritional assessment as well. We know that your older patients don't have as much nutritional stores, so they may be a little more sensitive when there's changes like this. So some of the things we look at in the subjective data for the comprehensive assessment is their height and usual weight, any weight loss or gain, any specific diet they're on, fluids, any changes in appetite, taste, or smell, difficulties chewing or swallowing, any allergies or intolerances, things that any preferences they have, any chronic illnesses that they have been impacting their health, Are they taking any vitamins or medications, any herbal supplements, things like that? You're always going to want to document those things. Um, if you're talking to them about their lifestyle, definitely fast food is a consideration. Do they cook their own meals? Or things like that. So some of the objective data that you might look at for this patient is, are they alert and oriented? Is their skin dry and intact? Do they have good tone and texture? That tells you about some of their hydration. If they have thin hair or brittle nails, maybe some issues, low protein possibly. Is their body proportionate? Do they have muscles that are firm and well developed? And then equal fat distribution throughout the body. So if patients are obese or have excess fatty tissue versus undernourished, those are differences in their subcutaneous fat. And we can definitely see that difference when we're looking at some of these patients. So there is also an anthropometric measurement called basic metabolic index. So this is your height and weight calculated to find the basic metabolic index. And so this is the BMI is what we use for weight-based medications, is what their BMI is. And so this is what Weber and Kelly has as your expected BMIs. And this is not a diagnostic of health status. It is a tool or a piece of the puzzle, but it is not the entire puzzle, because if you are have a heavier weight, but you're still very fit, that may skew some of your BMI results, and we see that in patients. So we want to make sure that it is a piece of the puzzle, not the whole. So assessing hydration, we're going to calculate how much the patient's taking in by mouth and how much they are taking in by their IV. If there's any irrigation or medications in solutions, we take that in consideration. Tube feedings or enteric feedings, which means they're given feedings through the NG tube or through a G tube. We will expect whatever we put in is being processed and coming out in outputs. If your patient has a stable weight changes with less than 2 to 3 pounds over 5 days, we're not really concerned about that. But if your patient gains or loses 6 to 10 pounds in a week or less, this is a pretty big fluid shift, and we would be paying attention to that. We'd also assess for any orthostatic changes. So again, the more volume you have in the body, the more the blood pressure is going to be increased. So when blood pressures are dropping, etc., we are looking at hydration as well. So fluid volume deficits can cause the blood pressure to drop. Now, skin turgor is where we pinch a fold of skin and we see, does the skin stay tented up, or does it resume? Is it elastic enough to where it returns to its previous state? When we check for pitting edema, we're using our thumbs, we're pressing in pre-tibial space and releasing our thumbs and seeing if that skin returns to the surface. If there's an indentation, then we're going to count how many seconds until that indentation goes away. But that is a sign of fluid retention. We assess the skin for moisture. Do we have moisture in the oral mucosa? Do we have moisture on your hands? Have you ever had really dry hands or dry lips? You know that those may be related to hydration issues. Also, listening to lung sounds. When patients have excess overhydration, again, pulmonary edema, crackles in the lungs sometimes. So in summary, Overall health status, your nutrition and hydration deficits, malnutrition, overnutrition, dehydration, overhydration. You're going to want to know the impact of all of those and some of the findings that you would see with those. Know your nutritional assessments, the screenings, etc. Some of the things we're looking for in our health history and objective data findings. Um, know some of the basic measurements that we utilize for nutrition, height, weight, BMI. And how are you assessing hydration? How are you checking for edema? How are you checking for hydration for your patient? And then we talked about those basic lab tests from earlier. These are good for you to know, and they're lab tests you're going to be assessing for every patient. Thank you.